There's no way we're monetizing this to become rich. We're doing this because this is what needs to be done in our profession, and I wanted to make it happen. This is a huge commitment for us.
At the intersection of airway, sleep, dentistry, and whole body health, 3 leading experts come together for one evidence-driven conversation. Dr. Barry Raphael, integrative orthodontist and co-founder of the Airway Collaborative. Dr. Richard Stevenson, award-winning educator, author, and authority in restorative dentistry. Dr. Mark Cruz, respected lecturer, clinician, and contributor to national dental research, where science meets clinical insight. This is Airway Nexus.
Hey everybody, welcome to another episode of the Airway Nexus. Hey Rich, how you doing?
I'm doing great, Mark. How you doing?
Good. Really excited to talk about our topic today. Super excited about it. So, what's up, man?
Well, we have come up with an amazing curriculum, and we call it the Airway Nexus. And I think it's important for us to talk a little bit about why we think it's so important that this kind of education exists today. And I think probably one good way to kind of break the ice is to ask you, and you've said this many times, that we don't treat sleep per se. We basically help sleep when we treat breathing, or basically another way. The thing that we said is, every smile begins with a breath, and I think you need to clarify that a little bit, because I think most people listening probably don't really have a good handle on what we mean when we talk about airway-focused dentistry. I just don't think they do.
Yeah, no, I agree, and we can actually define what that means, but I think let's just kind of give it a dental context versus the foundational concept of the medical indications for dental treatment, which we'll talk about. But something that I think every dentist would relate to, and the public at large, is, smile design, right? Just digital smile design, aesthetic smile design. Well, when you really understand the concept of airway-focused dentistry, you're really treatment planning that smile by understanding the facial skeleton, right? So every smile begins with a breath, because the facial skeleton, one of its main moment-to-moment roles is breathing, right? The caliber and size of that airway. So nice, broad smile, great arc of smile, beautiful facial structure. That is synonymous, because form follows function, with good airway phenotype, if you will. Obviously, it's more complicated than that, but patient comes to you on Monday and wants to have a beautiful smile because they've got a worn dentition. Well, with an airway focus, you really look at the patient, and the conversation is very different than the traditional, all right, let's go ahead and do a diagnostic wax up, let's go ahead and do our photogrammetry, let's go ahead and understand arc of smile, display, proportion, arrangement, all those things, pink and white aesthetics that have been taught in the last 15 to 20 years. Very different. That's a subset, if you will, of the underlying foundational concept of an airway-focused approach. Make sense?
Absolutely, it does. So, to me, that makes sense anyway. I think that, when most people think about airway, I think they're just distilling it down to the what their role is in sleep dentistry / sleep apnea. And I think that's one great big camp of people that are out there looking for courses, what's my role in this? Can I make a living doing this? What kind of compensation can I have? Can I really help people? How do I make these devices? What's the best company? What am I looking for? How do I get paid? Should I take Medicare? Should I work with a physician? How does it all work? Right. And there's that whole huge industry that is this, this end stage of this illness that's out there. And then also, certainly emerging, and growing in popularity is the expansion orthodontic mindset. And those courses are filling up and people are taking them in droves. But what I'm hearing is that people take the courses, they understand the concepts about expansion is part of the puzzle, but I don't really think that they've been even given the pieces to complete the puzzle. They don't even know what the puzzle's even supposed to look like when it's completed. So it's a little bit of it looks good and you're seeking something that you think is going to help you, and then you take the course and you kind of go, yeah, even if I could expand, what am I really trying to do here? I mean, it seems like maybe I should just refer to the orthodontist. I mean, that's what their specialty is. And so I have encountered these two huge groups of people. But then also at the same time, I'm getting the message that there are some courses that are more than that, that somehow pick up a lot on the Airway mini residency that you used to conduct for well over a decade. You and Barry Rayfield did that, and they have a lot of that built into it, which sounds interesting. Some of those courses are out there, but I think they're missing a huge piece that the Airway Nexus is going to introduce, and I don't know. I throw that back to you and comment on what my perspective, if that fits with what you're seeing, and then what you see as the missing piece or the pieces that would help a clinician truly transform their practice and open their eyes to another whole way of looking at their patients.
Yeah, no, there's a lot there, and we'll get into the details.
Sorry.
No, it's good. But I've got the bullet points in my head here, so we'll get into the brass tacks of, if you will, on the curriculum that ends up with a fellowship. Basically, you become a diplomat. Now, let me make this very clear: this is not sleep dentistry. There's, like you said, there is that camp, the AADSM, the American Academy of Dental Sleep Medicine. This has very little to do with that. Has very little to do with sleep apnea, other than the fact that, we'll see patients that have that end stage diagnosis, but it's really not. I mean, as I say, that's the tip of the iceberg. We're really actually dealing with the base of that iceberg in airway, and that's really what's missing. I'm not interested, nor was I ever interested, in appliance therapy, a management, if you will. So you solve one problem short term and you create another. We have a whole generation of patients that we're dealing with that, whether it's condylar position or changes due to using MADs, mandibular repositioning appliances, and they're focusing on just one segment of that whole spectrum. And
can I stop you there real quick?
Yeah.
Most people don't understand it's a spectrum. Honestly, they don't think of it as a spectrum, and yet I do, you do, we know that's what it is. So can you just talk a little bit about what that is? I mean, let's look at the long arc of the airway disease, if you want to call it, or it's not really a disease per se, but it's a structure, function, behavior construct that starts really early and goes all the way to the end of life. And patients that have sleep apnea today probably could have been helped a long time before, earlier. Yeah. There are ways to recognize who will ultimately end up in these end stages and catch them much earlier, more preventive. And I think that's where people, there's a lot of misunderstanding, or maybe they're just, frankly, they don't understand that is even a possibility.
Yeah, no question. And first of all, let me just backtrack just a little bit, because you are an educator and you have, your teaching institution. You were the department chair of the restorative department at UCLA. You have your fingers on the pulse of what the dental provider is doing in the way of continuing education out there. I mean, because you live that day to day, more so than even clinical dentistry. As fine a clinical dentist as you are, your focus is on really understanding education. You've been an educator, and you're that rare combination of an educator that actually can do it as a clinician. So I'm just going to say that because you have your fingers on the pulse and understand that, I have a respect for that and understand exactly what you're saying, that people are thinking that it's about appliance therapy and it's just another weekend course you can learn, or if you want to become a diplomat in dental sleep medicine, I think that's a mistake. That is an absolute mistake, and there are lots of reasons for it, and it's no different than what medicine is going through now, where the specialty of sleep medicine is a dying specialty for the same reason. But to go back to the spectrum of sleep disorders, let's just say that what we talk about in the Airway Nexus is the entire timeline from that first breath when you're born all the way to the end stage when you die, right? So each of that, in the entire timeline, there is a spectrum of degrees of severity and progression, but also there is a spectrum of age, right? So it's a couple of things. So if you're a pediatric dentist, you're going to be dealing on that epoch, if you will, of the spectrum in pediatrics. If you're, say, a prosthodontist or someone that focuses on temporomandibular disorders, you might be more towards the end stage or middle to end stage of the spectrum. And I think that's a mistake intellectually, because that means you really are not understanding the problem of an airway-focused problem. And this is why the Airway Nexus curriculum is the solution, because it really gets into understanding the entire spectrum from the innocent snore in pediatrics to, which is quote unquote innocent, to full-blown end-stage severe sleep apnea, all of which will give you information diagnostically as far as prognosis, as far as morbidity, as far as what the interventions that you would take and the team that you would put together, all the things that we'll get into maybe a little bit more detail in a little bit. But I think what's exciting is that we're actually talking about something that no one is right now. I guarantee you, I just as much know as you do of what's out there. And yes, there are courses that are bringing in, they might bring a token sleep physician to talk about it, or they might talk a little bit about skeletal expansion, because it's a widget. You can monetize that, right? On Monday, right. You learn how to do that. But there are major problems with that, because how do you talk to your patient about it? What's driving it? Is it intermolar width? Really? Is it, if they're not wide enough, what's the number you expand to? So I think those are all really in my opinion, misguided understanding of what's going on. And yet that's where everyone's jumping into it. So I think we need to be careful about that. So to answer your question, I think that's what the issues are, is that there is a spectrum and everyone is focusing just on the end stage. And even at that, sleep medicine and medical insurance is reticent to really deal with it. And if you go into healthcare to really help your patients, but let's just say it's your neighbor, your friend, your spouse, your kid, you're going to take it very seriously for them in addressing this for the rest of their life, right? You're going to get early intervention. You're really going to understand why they're so symptomatic when it's early onset versus while they're not so symptomatic when it's late stage, because there's been so much damage to the brain. So the signaling that and the autonomic nervous system that's been hammered is not working. So you have this false sense of security that it's not that big of a problem. A little bit of snore. I just sleep in a different bedroom. Mm-hmm. But that's where we get into the course. And what's exciting as just a regular dentist is that how you see the patient and really read what wear patterns, where it's in the anterior, in the posterior, whether it's a muscle temporomandibular problem related to the muscle, or a frank capsulitis in the joint, or whether there's erosion, why they have a reverse smile line.
How about a gummy smile, Mark? A gummy smile. You know, okay, I mean, I just got off a 30-minute Zoom consult with a patient that wants to have veneers, and highly educated, a patient that got referred to me, lives in a different state, and so it's common for me to have these initial meet and greet, conferences. And she believes that the solution to her gummy smile is a combination of Botox, crown lengthening, and veneers, and yet has the obvious phenotype of somebody that's suffering that we learn in our course. And the interesting thing is, I would have, even as maybe even a year ago, I would have entertained her proposal. Said, yeah, we can do that. But today our discussion veered in a different direction, where we actually we're talking about, identifying. She was coming to terms with identifying her own problems, and admitting to what she sees when she looks in the mirror, and was contributing her own symptoms that would alert us to a person that's that needs some assistance and needs our help.
Well, can I jump in right there?
Yeah.
Okay, so here's the interesting thing, is that you only know what you know. You only see what you know. And so what's happened is we've conditioned as a profession our patients that increasingly are becoming educated by going on social media, Instagram, YouTube, talking to influencers in short snippets of 2-minute discussions of, you could use Botox for the hyperactive lip to deal with that gummy smile, or veneers, and this combination, especially now with what we talked about in the past, is looks maxing, for example. People are really more consciously aware of, but they just don't understand, and neither does a provider, because that's what we were taught, right? You know why? Because we didn't understand that of what we could do in controlling the foundation of what houses the teeth. As I say, treating the patient attached to the teeth rather than just focusing on the teeth attached to the patients. That's how we were all trained, right? So when you have a patient like that, I look and say, I understand. I mean, I would say the same thing. And then you start asking questions that the answers to what you already know with an Airway-Focused, where the patient starts coming back and going, wow, I get that, I understand. Well, how did you know that? And then they almost lead you. You can more properly co-diagnose, and they start understanding that the problem that they're looking at, that they want to fix, is just one sign, if you will, or a symptom of a deeper problem that, had they known that it was connected, they'd be more motivated to fixing, which is their ability to breathe through the nose, keep the lips together, sleep deeply, wake up energetic, regulate metabolically, keep their blood pressure, all those things that also cause dental problems, clenching, grinding, TMD. So as you start going through that, that patient now goes to where the veneers and the Botox and all those things, they may be tools in our tool chest for sure, but they might be put off after you've addressed the root cause or the foundational things. You've maybe expanded, maybe you did some corticoids, clear aligners, or whatever mechanics that you want to increase oral volume so that they're breathing and sleeping better, the tongue is not obstructing them as much. You're dealing with the myofunction and the behavior and all those things. And then at the end, depending on how severe the case is, how old the patient is, how healthy they are, you still may use some of those tools. But now they're going to be more precisely used with better prognosis. And so spend a whole podcast just on what we didn't know about with the typical gummy smile diagnosis, right? VME, dental
True.
extrusion, hyperactive lip, that is now really changed dramatically. So as a dentist, if you're
Yeah.
listening, that's antiquated. It's stale information because
Oh,
we now
absolutely.
know more
Yeah.
information, right? So that patient you talked about, does
Oh,
that make sense?
oh, it does, and it's like the diagnosis of the gummy smile, the 7 possible diagnoses. I look at every one of those diagnoses, and they all have a common,
Yes.
source, and it's
Phenotype.
absolutely the
Yeah.
phenotype of the air. It's an airway related issue, no matter which one you're looking at. Anyway, I think that's really interesting. I wanted to talk a little bit about the architecture of our course and why it's different.
Yeah.
And I'll say a few things. And
Okay.
first off, and as an educator, I really believe that I've come to terms with, the right amount of education and not we always talk about over treating the wrong problem. We
Yeah.
don't want to over educate the dentist, and so but we also don't want to leave things behind. So we really thought about this a lot, and this is really, there's a movie called, Mr. Holland's Opus. This has got to be, Dr. Cruz and Stevenson's opus, because this is the 32-day plan that I think you and I have just always, well, you have, but more recently for me, I thought that would really be the right number of days to commit. You go to I'm a graduate of the Coist Center, that's 27 days. And not one day of that, when I took it, had airway involved. We're talking about a 32-day course that covers, in depth, the identification, stabilization, the mastery, all the widgets too. By the way, we love widgets, Mark. Widgets are cool.
Sure.
They're cool. I mean, I like designing them. I like placing them. I think Marpies are amazing, and I think knowing how to use them is a great skill set and everything else. It's not like we're not including that, but
Including, by the way, mandibular advancement devices. We still use those too. But
absolutely,
it's just one tool in a big tool chest with the proper indications. Yeah.
you got it.
Go on, I'm sorry.
No, and it's like we have a 256-hour program. I mean, this is serious, and going all the way from the initial identification, where you know nothing, all the way to the most complex surgical interventions, working with allied health, individuals, rehabilitation. All of that would be included. And the thing that makes it really different, and that's something that you and I know very well, is that study group component to it, where we are including clinical care of patients over almost like it's like a mentored year of clinical dentistry, where we provide all the patients in a really wonderful state-of-the-art facility, and you get to actually learn through treating patients. And that's not all, because every single, and I've never heard anything like this, Mark, but every part of the course, every pillar, if you will, has 2 follow-up Zoom meetings where we meet with everybody and we talk about what we learned, any questions. I mean, who's doing stuff like that? I mean, that's amazing.
But it's required to keep people on task, because everyone's a clinician. They've got their lives. They go home to families. We get that. And I just have to say, Rich, one of the things that's wonderful and how we got back together as classmates, and after many years, you mostly in education, me mostly in clinical practice, although we both have dabbled in the other realm, is that, for now we're well over 15 years, actually it's closer to now 18 years, where I was giving these courses when no one was really giving any of these courses. It was very, very small, and then it started growing, and Barry and I started giving them. The mistake that we made, if you will, was we focused on the theory, giving all the different aspects of it: craniofacial growth and development, epigenetics, looking at medical comorbidities, dental comorbidities, looking at the use, the importance of allied health and function. We had all these 12 chapters that we brought together over well over 100 hours of continuing education that was in the classroom, if you will. But when all was said and done, everyone saw it and they were very excited about it. But what we didn't do is really provide a concrete way of translating it into real world practice on Monday. And a lot of mistakes were made. And actually, it's what seeded and gave rise, I'm confident, in a lot of what you're seeing out there right now. Because I know the people that are out there that are doing this, and that's great. I mean, one of our taglines was secondary goal of teaching the teachers, which is, what's happening. Barry and I were talking the other day of saying, see, this is what's happened. We've taught the teachers and they're out there and they've influenced other people. And this is exactly what we wanted. We wanted to be open source, to raise the awareness that we weren't crazy about it and that the orthodontic specialty was more and more increasingly feeling the pressure of not doing business as usual and just straightening teeth out. Okay, so I think what's different here is that you went through that program when you asked to learn more about it. You had already kind of had some background in it, and then you went through it twice. And with your eyes as an educator, you were able to help develop a much better curriculum that allows the dentist on Monday to start translating into real world practice, getting patients scheduled for treatment right away for evaluations, and be able to actually increase the spectrum of services, if you will, for the patient that makes them healthier as they're going through it. So it wasn't something that you'd have to go through 2 years and then you start doing that. Well, that was a mistake.
Do it right away. No, right away.
That mistake, right?
Right away. It's there's still a fair amount of classroom work, but there's always clinical relevance, translational discussions. You're constantly bringing up cases, in the world class presentations that you give, Mark. We have patients that we bring in and do demos on. Even in the identifier and stabilizer, the pillar 1 and 2 courses, we still will bring in patients and show exams and question the Q&A part, photography and stuff. But it's basically to introduce those concepts. And then the mastery series after that, either these 2 or 3 day courses that get added on, allow the clinician to pick up on those whenever they can, because we're also super busy. So, but those take a deeper dive. For example, going into a corticotomy course with surgically facilitated orthodontic treatment, another course on the orthotropics and pediatric airway
and all that.
focus.
Yeah.
Right. I mean, so if you think about it, I mean, here's what I appreciate your compliments and also recognizing that the synergism of our two experiences of the world and dentistry and healthcare have really made for a much bigger volume of potential that we could have done individually, and it's summative. I mean, it's kind of an exponential thing. And I thought to myself, what would I personally want? What would I want if I was 1 year out of dental school? What would I want if I were 10 years, 15, 20? So, and I thought, you got to make it, it's got to be accessible. We got to figure out a way to make it very translational. And people almost, I would love to say the tuition for the course could be paid for with just the patients they'd start seeing almost immediately. It's not like, oh, it's going to happen 2 years from now or whatever when you graduate. No, you're already seeing the benefits of this right away. For example, I ran residency programs, right, at UCLA. When we accepted a resident, they would get super excited about working on patients and doing all this kind of stuff. And they would start producing for us. They would start producing for the clinic, and we needed them to produce for the clinic. And so they didn't have to wait till they finished the program to start working on patients. That was part of the process of learning. So I just am really, really proud of this, because this is going to allow people to engage in patient care immediately after just 6 days. After 6 days, boom, you're in the clinic and engage in patient care, and then taking
like a residency or a fellowship, right? Hey, have you ever seen the series, The Pit, HBO series, The Pit?
Oh, yeah.
Yeah, right. It's a little bit like that. You're in the emergency room, and then you've got the interns, and then you've got the first year, second year residents, and then you've got the attendings, and you've got this hierarchy, and then you've got all hell breaking loose. And everyone's got to go in there, and you're, a first year resident, you're placing a chest tube, right? The first one that it's like, you cannot do that unless you've got an experienced provider that's there to help you to do your first one, and you learn. Well, the thing that I'm excited about in our program, and it would have been great if I would have had this myself, and certainly did in our hands-on restorative study groups that I was in, where we were seeing patients, we had a mentor, and that helped tremendously, even after years of practice, where they it wasn't like you were still just out of dental school. You still had a mentor kind of giving you some things that really accelerated your learning curve, efficiency, diagnostic skills, and all that. But if, let's say, you want to learn how to do ALF or BioBlock orthotropics, just as an example, you actually will be able to learn by doing it after a lecture, actually seeing a patient, and seeing that patient all the way through. There isn't anywhere in the country that you do that. There are many residencies where you go and you watch someone else do it and talk about it, but on Monday you've got to go in there and say, well, how do I adjust that class? Same thing with the ALF. You watch other people do it, you kind of learn it. Well, this is actually where you do it. Same thing with Marby, placing your pads the first time. You're actually doing it. If you want to do the surgery for corticotomies, we're going to teach you that, because we've got a faculty so that's what I'm excited about.
Yeah, I mean, and I know what other courses run financially, and I don't want to get into the finances too deeply right now, but I do want to just say that the clinical involvement in this program is significantly less of investment and you're treating the patients versus one where you actually watch someone do the work and you pay more. So it's like, wait a minute, there's a little disconnect there. We just understand that the way to really jump through to the next level is to truly have the hands-on experience. And just telling people to go do it in your practice and let us know how it goes and show us your cases, that's fine. But if you came to a center and you were assigned a patient and you had to work on that patient, but you did it under a mentorship situation where you and I and the other incredible faculty that we have will be engaged in the person learning and the whole experience, and getting the patients committed to the work. And the patients love the experience because they just know it's very transparent. Patients love this because they're like, oh my gosh, there's nowhere I can go to get this work where there's a group of people that are it's like this second, third, and fourth opinion all built in. It's all part of the treatment. There's nothing like this except for the study clubs, and there's very few of them anymore.
Or dental school residencies.
Right.
And they're struggling because they are going out to community centers. But the thing is, and this is my pet peeve, and why I'm excited, because this is a solution, is even faculty that I've had before that knew a lot, because let's say they had gone through the curriculum. They knew a lot, but they'd never really treated a patient. And they could talk like an expert on what device, but they never actually had to troubleshoot any. What happens when you're placing your first Marby? Wow. You went through a weekend course, and the head strips as you're placing it. Who's going to be there to help you troubleshoot that? in real time. So
Yeah.
you'll only do one of those and then you're going to say no more. The thing is, you've got to make some mistakes in the clinical setting, and we're there to help because we know what those mistakes are going to be before they happen. And so we guide you through it. And the other thing is that you get the confidence that on Monday, you're now treatment planning them on your own patients. And we have case reviews like on the Zooms to answer those questions and to help troubleshoot. But you first have to have your gloves, if you will, wet. And that's what I'm excited about. And this is a solution, Rich. Honestly, you only learn by doing it. In academics, you get very smart people, but if I'm going to have my chest cracked open, I'm not necessarily going to go to that ivory tower clinician that did a lot of research on it and knows a lot about it, but has only cracks the chest open once every 2 months. I'm going to go to the guy in Dallas at that maybe university-based teaching hospital, but he's got a private practice, that he's doing it all the time. Maybe that's not a good example, but we get into things like planning maxillomandibular advancement surgery. I argue that every dentist should know what's involved, how to decompensate in preparation for that, treatment plan it, and be an integral member of doing that. Not that they're necessarily going to do the Lafort cuts, but they should be in the OR at least a few times to see it if they get interested and want to go down that path. Now, if you're treating kids, early intervention, that's a different population, and that's the nice thing about this program. No matter where you are in that spectrum, pediatrics, full complex pros with implants, or surgery or surgical track, we cover those bases. But everyone learns from everybody else, because if you're treating adults, you got to know where the problem begins, and if you're treating kids, you got to know where it's going to go if you don't treat it. So that's what I like about it, if that makes sense.
Yeah, you brought up that last point about, you kind of alluded to who could benefit from learning this, and I'm going to tell you right away that if I'm a pediatric dentist, and you can tell I'm respectful of my colleagues that are pediatric dentists, because I don't call you a pedodontist, because that's not respectful, right? You're a pediatric dentist, and if you don't understand airway, you're kind of missing the main reason probably why you became pediatric dentist. I mean it. It's so huge. If you're an orthodontist and you're stuck in the white paper mentality, and then you're worried that there's another opinion, and there's a lot of confusion. The dust is definitely is being plumed everywhere.
Or it interferes with your financial model, your practice model.
Oh yeah, for sure. And then you mentioned about I think, if you're oral facial pain person, or you're a new specially trained OFP, oral medicine, and you don't understand this, oh my gosh, it's so huge that you're missing one of the most important aspects of your practice. If you're a prosthodontist and you start doing pros on patients with wear, because that's what you do, you treat the worn dentition, that's a lot of what you do in pros, and you don't understand why it happened, and you believe it was just, no one knows, it's just erosion, it's attrition, it's a bruxism, blah, 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 and you don't understand what's behind it, your cases are going to fail sooner. I absolutely know that to be for sure going to happen. You're not going to get the kind of longevity out of your cases. I just think that the general dentist, the pediatric dentist, the orthodontist, the prosthodontist, the oral facial pain. Am I missing anybody? I mean,
periodontist,
absolutely, periodontist. My God, I'm sorry, periodontist. Of course,
right.
huge part of this. So it just seems like look, we're not gonna, Mark. Here's the deal. There's no way we're monetizing this to become rich. We're doing this because this is what needs to be done in our profession, and I wanted to make it happen. This is a huge commitment for us. The amount of time that we have to put into this is mind-boggling. the planning, the staff involvement. Your staff, my staff, we're constantly on top of this, developing teaching materials, carving out the space in our busy lives to make it happen, making sure the facility is in perfect condition, getting everything in gear. We can't take more than
let me make a prediction.
We can't take a huge cohort for this. We're not filling a lecture room for this. We're talking about 12 to 16 people in the clinic, maybe up to 24 or 28 people or something listening to the lecture modules or the breakout modules, but the mastery modules. But for the clinic part of it, it's very highly mentored in a high level.
Okay, Rich, let me make a prediction.
Yeah.
I believe that this model, so it's think of it, this is not a CE, this is actually a model that is the future, that dental schools will eventually have a program like this. And the problem why it cannot work right now in dental schools is because the way the education is so siloed. You've got, the orthodontist in one place, you got the periodontist in the other, you got the prosthodontist. No one's talking to each other in their education. You've got their attendings, and that's all fine and good. To do this, plus you don't have the faculty that understands and transcends.
Yeah, who's trained? Yeah, they're not trained.
Right.
No way.
And so we're going to bring our cumulative 80 years of plus of practice and the seasoned faculty, world-class faculty, both in medicine and dentistry, by the way, right?
Oh, I would agree.
In this program to rock your world, and I think more importantly, your community's health, the health of your community that you're in. And one last really important point that needs to be cleared. One of the very important foundational concepts is the medical indications for why you would do dental intervention. So let me just use an example for a MARPE, a skeletal expander. If you take a weekend course and you learn how to do it, and you're a general dentist, and you go back on Monday, your treatment planning, it based on a phenotype. You're looking at intermolar width, this person's, narrow, and you could talk to the patient about it, and the patient may or may not buy in and want it. But when you understand and ask the right questions on the medical indications, which you're not doing now, and that the reason why you would do a MARPE has to do with the breathing and the sleep and the comorbidities and all those complaints that are being treated in isolation by the physician, either with anxiolytics, proton pump inhibitors, antidepressants, hypertensive drugs, that they start understanding that they can get off of those medications or greatly ameliorate it and feel better. They're going to want the MARPE, not because they want the MARPE, but because they want to be healthier. And the MARPE is just a tool, right, for them to become healthier. The discussion and the acceptance of the treatment goes very differently than, I just want a wider smile. It looks better. And I think that's really important, of something that no one's really talking about. I mean, they give it lip service, maybe you stop your snoring if you're using a mandibular advancement appliance. Okay, fine. But that's not really, people are lukewarm about that. What I love is it's transformational for your practice because people are not lukewarm about it. They're like, I'm all over this. Now you're going to treat my spouse. I've got my kids, my neighbors, and it really builds your practice in such a meaningful way where you're doing increasingly complex treatment in an interdisciplinary fashion that's super professionally satisfying, way beyond the fee. And I think that's why we went into healthcare is, honestly, if I had a line out the door to do full mouth rehabs and veneers, I'm like going, really? I'll do as many as I can, and I'm going to be beat up at the end of 2 years. And at the end of it, what have I really done? Maybe I funded my 401k, but I've not moved the needle in the health of, my community, and maybe I've got this reputation for doing some, really nice white smiles, that's already out there. It's worn. This is very different. It's a completely different path that really pulls us back into the mainstay or main path of health and wellness.
Yeah.
And that's what the program's all about. You get the foundation, and then depending on where you are, you start taking all the courses. And one last thing about the curriculum in the second pillar is we also teach those basics, right? Optimal scanning, the optimal photographic setup in photography. There are a lot of courses on it, but it's going to be different with the gallery that you take for airway. The extraoral, the intraoral, because that's also going to help you with your planning of your simulation for your clear aligner. So we're going to teach you all those things. Even if you're very seasoned, I will guarantee you will learn a lot. And so
I agree. I agree.
I think it's exciting for everybody. And thank you, Rich, for taking your expertise as just such a respected educator, because I didn't see it. I didn't have the wherewithal. I'll say I didn't have the wherewithal to really understand what was I missing, because I got it right and I was practicing it right, but I could never scale. For a colleague, I could get on a Zoom here or there, but I could never really scale, even though we had courses on medical billing and consulting on how to set up things. It just wasn't scalable. And you were able to help provide the solution in this amazing fellowship that, by the way, when all is said and done, there will be a written test, there will be a practical, but you're going to need that to feel super confident. And by the way, also to help teach it yourself. We want to do it in a much deeper way than someone that published 1 or 2 papers in some university, but at the end of the day, you're still doing dentistry, even if it's within a specialty. I think this is very different.
Yeah, I mean, I see a future where our graduates are educators running, similar programs in other locations, or maybe working out of our location, but I know you're a big thinker, and you're seeing how this can be into the dental schools, the country, and the world. And it's got to start somewhere. One of the things that people ask me is about how much does it all cost, and like I said, I mean, let's put it this way: if you want to do this, there's a way to make it work, because it's like, even when you buy a nice car, you don't just plop down the whole amount at once. There are ways to work it out. And we're building this one person at a time, Mark. And one of the things we're doing is that the doctors who are interested in becoming members of this, we're taking very seriously. And it's a little bit of, we want to know what your motivation is as much as you're asking us what they're going to receive, because it's a two-way street. We want winners that are looking to be fully committed, and we will talk to them on the phone before we green light them to even enroll in the course. It needs to happen that way. This is a very important way for us to start the Airway Nexus. It's not new to us. Nothing in this course is new in terms of content. It's already
in a textbook, by the way.
It's in your textbook. It's IP. I mean, we've got the intellectual property. We've got all of this already.
And the responsibility of them treating patients, right? I mean, we can't spend any time remediating.
Right. We need serious people that are going to look to get this thing done in somewhere between 1 and 3 years. We're not even letting people take longer than 3 years. You have to commit to it and get it done. So maybe 1 year you take the 2 courses, and then you start the mentored year of working on patients, and then throughout the next year and a half, you continue to take these mastery modules along the way. And as long as you complete everything, and you complete an examination, and you presented your cases, then you can be a graduate, you can be a fellow.
But one other thing, Rich,
yeah.
It's also Well, two other things that are super unique and features of the program that no one has also is we actually have a very robust course curriculum on how you actually translate it in real world practice.
For
From
sure.
medical billing to workflows,
Yep.
to verbal skills, to training your staff, because we believe this is real world. This is not like you go ahead and do all this curriculum and then it's interesting, but how do I actually make it work? And that's what the mistake I made for so many years is I wasn't able to really solve that part of the problem. Well, we've solved that, number one. Number two is we actually have an electronic platform that houses all our lectures, all our videos, all the case report.
You're talking about the Airway Collaborative platform.
So you've got your cases on Monday. In between the sessions, you're going to be posting those cases in a HIPAA platform, like an EMR, if you will, and you're going to have a whole community chiming in and talking about it. And so no one else does that, and that is necessary, by the way, if we're going to do this. Unless you stop and take a hiatus of 2 to 3 years, like a sabbatical, and then go full-time academia, fine, you could do that. We know that we're really working with people that are working full-time and have families, but still provide a rigorous, robust curriculum. So I just wanted to say those are the last two to go along with it. But with that, I mean, I think we could just conclude by saying, wow. And I would say, how do people find out about it, Rich? And then we'll end our podcast.
Honestly, the Airway Nexus is going to be live very, very soon. The portal is going to be ready very, very soon. Until it is available, you can take advantage of going onto the Stevenson Dental Solutions website and checking out the Pillar 1 and Pillar 2 courses.
Which are requirements.
Pardon me?
Which are requirements of the Airway.
Oh, they're required anyway.
So they can start on that and then continue on the...
Take them now, and then when the Nexus is fully online in 2027, you will have already completed the first 2 pillars of a 4-pillar program. So I think that's what I would do. Anybody interested can go there. They could reach out to me at my email, which is rgs@stevensondentalsolutions.com. I'd be happy to engage in conversation with you, get on the phone, and help you understand a little bit better about how the whole thing works. Mark, I'll tell you something. You're right. I teach a lot of courses in just good restorative dentistry. And I even have a course starting tomorrow, a 2-day course, which is sold out. And every course that I teach, I talk about the importance of understanding the concepts of airway and how it is a modifier of everything. The interest in doing an airway course is enormous. And interestingly, a lot of them are asking me, so Dr. Stevenson, what course do you think I should take? I heard about this course. I heard about this course. I heard about this course. And I look at them and go, take our course. We have a course. They go, oh, you do. So I think it's kind of interesting. They really want to do this. I mean, nobody wants to jump around and take a bunch of courses that don't add up to something that's translatable to your practice. You need to be able to make this work for you. You need to see a proof of concept. And so what better way to do that than have all in one stop, this is it.
And go to the OG.
Yep. It's kind of like if you had to build a house, and you had to take care of all the subcontractors yourself and all that stuff. I mean, come on, you go to a builder that knows what they're doing, an architect and a builder, and they take care of the house for you. They understand how to do this. You don't go around and go to Home Depot and buy the materials. You my goodness, you get professionals to help you to the point where you can pop out the other end and have the credentials that you have worked hard at, that have been given to you in a very clear way. And I think that's what this does for people. And to me, it's a no-brainer.
Yeah, no, great, Rich. Thanks for that. And we'll continue talking about our other airway topics that we talk about in this podcast. But I was really excited about this particular podcast.
Well, me too. Yeah.
Talk about really, because we need more people that are properly trained, way beyond schlepping widgets, to comprehensively diagnose and treat the patient with interdisciplinary care. So we'll continue that conversation. But thanks, for sharing that information. Thanks to you for really putting so much of this together in such a meaningful way. So with that, thanks everybody for joining us on another podcast, and we'll see you at the next one.
See you next time, guys.
Signing off. Take care.